This is the Pick Your Poison podcast. I'm your host, Dr. JP, and I'm here to share my passion for poisons in this interactive show. Will our patients survive this podcast? It's up to you and the choices you make. Our episode today is called Bitten. Want to know what antidote has caused more deaths than the toxin itself? And what type of bite has been mistaken for appendicitis? Then listen to find out. Today's episode starts in the emergency department. You hear commotion and shouting from room 1. Inside, several nurses and techs are trying to get a small boy undressed. His parents are shouting, "Do something! He needs help!" You're tempted to walk past and let your colleague handle this one, but instead you enter and ask what's happening. The parents start shouting at you to do something. You try to calm them down to get a history so you can potentially intervene. The patient, 5 years old, is lying on the stretcher, crying and grimacing in pain. His knees are drawn up to his chest. After much difficulty, you manage to obtain the following information. The patient was fine until 3 hours ago. He then told his mother his arm hurt, said he felt sick, and then threw up. Pain progressed, becoming severe and encompassing his entire body. He has no other symptoms, including constipation or diarrhea. He hasn't had a fever. He doesn't have any past medical history and doesn't take any medicines. The nurses are having difficulty getting him undressed because he doesn't want them to move his limbs. The parents want his clothes left on. They refuse to allow a gown until he's given pain medicine. The patient screams out every few seconds and is crying nonstop. You agree to the pain medicine, hoping this will expedite the patient's care. He's obviously unwell, and prolonged arguing with the parents isn't in the patient's best interest. The nurses do manage to get vital signs as follows. Temperature is 98.5 Fahrenheit or 36.9 Celsius. Heart rate 130 beats per minute. Respiratory rate is 40 breaths per minute. Oxygen saturation 100% on room air. And blood pressure is 140/80. You do a limited physical exam over his clothes. He's sweating profusely, diaphoretic in medical terms. He's crying and won't answer questions, so that's all you can gather about his mental status. His lungs are clear, though he's breathing rapidly. His heart rate also rapid, but otherwise normal. His abdomen feels hard and rigid. A rigid abdomen is often caused by peritonitis, infection inside the abdomen, for example, from a ruptured appendix. He doesn't have focal tenderness in one area, but rather pain all over. The muscles in his extremities are twitching. The nurse places an IV, and you order a dose of morphine, some nausea medicine, and IV fluids. So what now? Clearly we need labs and a CAT scan of his abdomen to look for a source of infection. Is it appendicitis? The rigid abdomen suggests intra-abdominal pathology, yes, as I said. Patients with peritonitis don't want to move because that makes the pain worse, possibly explaining why he didn't want the nurses to get him undressed. You might have had appendicitis yourself or seen a family member with it. Were they twitching? No, something isn't right here. Question number 1. What electrolyte causes muscle spasms? A, calcium, B, potassium, C, magnesium, D, sodium. The answer is A. High calcium causes muscle spasms and tetany. Both high and low potassium can cause weakness, as does high magnesium, and sodium really has minimal extremity muscle effects. Hypercalcemia can cause constipation and thus abdominal pain, but it really doesn't cause this severe level of pain. The patient's lab results, including his calcium, are normal. There's no evidence of infection in the blood work. A urine specimen is normal, and his CAT scan is also normal. No ruptured appendix, and nothing else that would be causing peritonitis. So what's going on with this kid? You go back into the room. He's no longer crying after 2 doses of morphine, but he still looks very uncomfortable. He's grimacing. He's still sweating. His jaw is clenched tight. Is this rhesus sardonicus, the facial changes we discussed with strychnine in the culinary catastrophe episode? No, his mouth is clenched shut rather than pulled back into a dreadful smile. You didn't give the parents any morphine, but they've also calmed down, fortunately. The nurses managed to get the patient into a gown. Why is this gown so important? I found shingles, ticks, cellulitis, other infections, blood clots, fractures, and even a dislocation once in an intoxicated patient after undressing and thoroughly examining my patients. So you pull up the gown, noting his abdomen looks as rigid as it felt. You check his back to make sure there's no rash or infection, and then you give his skin a quick check. On the back of his left wrist is a red mark in a swollen circle. At first glance, it looks like an insect bite. On closer inspection, it's white in the center, called central pallor or central clearing. In the middle are 2 puncture wounds. Question number 2, and time to pick your poison. This is the classic description of what kind of sting or bite. A bee sting. B, a rattlesnake bite. C, a black widow spider bite. Or D, a brown recluse spider bite. The answer is C. This is a black widow spider bite. It's a good thing we got him undressed and did a thorough physical exam, otherwise we'd still be in the dark without a clue as to what's happening. This is a classic description of the bite, but what about the rest of the symptoms? Can a black widow cause this? Yes. In fact, clinically, I'd give more weight to the systemic symptoms in making the diagnosis than I would the way the bite itself looks. And more on this in a minute. You ask the parents about spiders and black widows. Mom looks baffled. Dad says he saw a black widow in the yard a few weeks ago. So what now? That's question number 3. A, obtain confirmatory testing. B, supportive care. C, suck out the venom. D, administer the antidote. The answer is D, administer the antidote, though if you said supportive care, that answer is actually also okay. We do have black widow spider antivenom, and I would give it to this patient, though there's some controversy about it. We'll come back to that in a minute. So you order a dose, it's 1 vial, and you're relieved when the pharmacy says they have it in stock. Not every hospital carries it. Black widow bites are fairly common, but most patients are fine with mild symptoms and don't require antidotal treatment. Unlike snake bites, the dose is always 1 vial. It's enough to neutralize the venom from 1 spider. This is also the reason that children are more affected than adults, because the amount of venom injected by the spider is much more potent in a child who weighs a few pounds or a few kilos than an adult who weighs many pounds or many kilos. 1 hour after administration of the antidote, the child is almost completely recovered. He's no longer having muscle twitching. His abdominal pain is resolved. He's still complaining of a little bit of pain in his left arm, but that too is improving. And he has a guilty look on his face every time someone mentions the spider, but hasn't been forthcoming about what happened. Widow spiders are found on every continent except Antarctica. In North America, we have the classic black widow Lactrodectus mactans. The spiders are usually found in wood piles, outhouses, and rubbish piles. They aren't typically aggressive towards humans. Black widow bites are immediately painful, and then systemic symptoms develop over several hours, anything from mild pain to severe envenomation, including whole body pain and spasms, sweating, high blood pressure, rapid heart rate, rapid breathing, severe abdominal pain, priapism, even myocardial infarction, seizures, hallucinations, and psychosis. No deaths are reported from black widows. 3 deaths are reported from other Lactrodectus species, 2 in Madagascar, 1 from cardiovascular failure and the other gangrene of the foot. A 3rd death in Greece was attributed to myocarditis or inflammation of the heart muscle. So what does black widow venom do? Well, it's a mixture of toxic compounds meant to paralyze the prey. The main culprit in human toxicity is alpha-latrotoxin. Remember I said hypercalcemia causes muscle spasms and tetany? Well, alpha-latrotoxin works by increasing calcium concentrations inside the cell, causing muscle twitching, spasms, and tetany. And in the face, this is called facies lactrodectismica. The antivenom is a horse-derived antibody that binds to the alpha-latrotoxin. It works really well, reducing symptom duration from 22 hours to 9. Onset is as rapid as 30 minutes, with most symptoms resolving 1 to 3 hours after administration. And when you use it, it really works amazingly well. It also reduces the need for hospital admission. So why then is it controversial? 2 patients have died from anaphylactic shock due to the antidote, and as I just said, no patients have ever died from a black widow bite, and that's the reason for the controversy. Both antivenom deaths were tragic, but they were also unusual cases. 1 patient with a history of asthma and allergies was given undiluted antivenom as a push rather than a standard dilution given as a slow infusion. So this was actually a medication error. She suffered anaphylactic shock, unusually complicated by a collapsed lung, and then died. A 2nd patient, also with asthma, developed anaphylactic shock and cardiac arrest. These were tragic cases, but again, since there were no deaths from black widows, it led to caution for many, many years in the use of the antivenom. But since then, the antivenom has been used safely in hundreds of patients. It isn't recommended for patients with mild symptoms, local symptoms only, or for those with asthma. Research is being done into a new antidote, a lab-manufactured antibody, presumably with a reduced risk of anaphylaxis. So what about brown widows, Lactrodectus geometricus? These aren't native to the U.S., but they're now spreading to many states. They have actually equally potent venom as black widows. However, their bites are less problematic because they inject a smaller amount of venom. And in many areas, black widows are declining. Why? Interestingly, due in part to the brown widows, because the brown widows hunt black widows. I want to share two historical cases with you. The first is from 1900. A San Francisco construction worker was bitten by a black widow, and after developing extreme pain, he was treated with potassium permanganate, cocaine, and morphine. Convinced he was dying, the patient treated himself with whiskey, and after severe ongoing symptoms, his physicians injected him with strychnine and whiskey, IV. The patient died 14 hours after the bite, likely killed by the treatment rather than the spider. Interestingly enough, there was controversy at this time as to whether black widows were actually venomous to humans. And so the second historical case definitively proved the answer to this question. On November 12, 1933, a physician named Alan Walker Blair conducted an experiment on himself. In his lab at the University of Alabama School of Medicine, he allowed a black widow to envenomate him and recorded exactly what happened. 20 minutes after the bite, his entire arm began to hurt, progressing to neck pain, chest pain, and abdominal pain. Several hours later, he was taken to the VA hospital due to the severity of his abdominal pain. He then developed difficulty speaking and was unable to stand up. Early the next morning, afraid he'd go insane, he was treated with morphine. His condition improved 36 hours after the bite. The initial plan was a second bite to see if immunity developed, lessening the effects. He said, quote, "I was presented with the opportunity of deciding this point, but lacked the courage to submit myself to a possible repetition of the first experience," end quote. So back to our patient. He finally admits to his parents he found the black widow spider while playing in the yard, put it on his arm, and poked it with a stick until it bit him. Why? He was hoping to turn into Spider-Man. Fortunately, he recovers uneventfully. Unfortunately, he doesn't develop any superpowers. This is a fictional case, as are all our cases, but based on the real case of several brothers in Bolivia who apparently all wanted to become Spider-Man. The last question in today's podcast. The red hourglass marking on spiders has been shown to protect against attacks from which of the following? A. Birds, B. Humans, C. Male black widow spiders, D. Wasps. Follow the Twitter and Instagram feeds, both at PickPoison1, and you'll see the answer when I post it. Remember, never try anything on this podcast at home or anywhere else. Thanks so much for your attention. It helps if you subscribe, leave reviews, and/or tell your friends. Transcripts are available on the website at pickpoison.com. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Thank you. Until next time, take care and stay safe.
This podcast is a production of Unfiltered Studios. If you would like to know more about joining Unfiltered Studios, please visit our website at unfpod.com for more information.